something that just gets repeated and repeated and repeated, and people have heard it so many times. It's just taught in medical school, but nobody asks, where does that come from? What's the origin of it? You know?
Well, I mean, the interesting thing was that I came across that when the genesis of my lecture on fiber came about. I was writing a a chapter for a medical textbook on nutrition. And as you know, when you're writing an academic text, everything needs to be referenced to the nth degree. And I was low carb at this stage, but I hadn't ever looked into the science of fiber. So I got to fiber and said, you know, recommendations. Yes, 30 grams of fiber a day is recommended for adults. Here's the reference. I looked at it and said, well, that's an advisory statement. You know what I think about advisory statements? Not much. Yeah. It's like, well, let me go to the advisory statement and I'll see where their references were. And I followed the chain back, and it would always stop. You could see an opinion, but nowhere was the evidence actually cited. And I'm like, well, this is odd. I mean, I'm looking at research on fiber, and there's a few things that are absolutely well known. So yes, it does increase the bulk of your feces. If you ingest something that the body can't absorb at all, then it's going to have to come out the other end. So your feces is going to be larger. That's obvious. It's an irritant, and it can increase transit time. So things can travel through your intestines quicker. Yes, that is true. But when we actually looked at it in terms of symptoms of constipation, so as a doctor, you don't have somebody come to you and say, oh, doc, just over the last few months, my poops have been quite small. There's no pain or bloating, but they're just a bit small. Do you think you could just make them a bit bigger? Or you don't have anybody saying, you know, look, I did a test, and it's taking 2.5 days for my contents to transit all the way through the gastrointestinal tract. Do you think you could speed that up 12 or 24 hours? I mean, people aren't aware of this. They have no symptoms. People care about pain. They care about bloating. They compare, you know, they complain about bleeding. These kind of things are actual genuine symptoms that adversely impact on people's lives. And when I went looking at the literature for evidence that fiber could benefit these things, the diagnostic symptoms of basically constipation we use in the clinic, the data was absent. And instead, I found a beautiful experimental trial where they actually put people on different levels of fiber in their diets. They had subjects who all had idiopathic constipation. So idiopathic, if you're not medically trained, so idio means idiot and pathic means pathetic. So it's just the diagnostic label a doctor gives to something when we don't understand it. So it's more a reflection on the doctor who'll give the diagnosis, because it's basically idiopathic means I don't understand it and I really have no intention of trying to find out. But anyway, so these people had constipation, idiopathic constipation, and they were all on, you know, moderately high fiber diets. So then a bunch of them were placed on even higher fiber diets, and across 5 domains, their symptoms all got worse. Then some of them were put on low fiber diets, and their symptoms across the board generally improved. And then a group of them, the largest cohort, were placed on 0 fiber diets. And in every case, all symptoms of constipation were completely eliminated. And to date, in terms of looking at symptoms of constipation, not fecal transit rate or mass or any of these, you know, surrogate markers which don't mean anything to the real patient, not the patients that I'm seeing, but the real things like pain and bloating, a 0 fiber diet was hugely, hugely successful. So this was a case where I'm sort of writing a textbook chapter and I'm sort of thinking, wow, my understanding is completely been thrown on its end. So I had a choice. I could either ignore the science and just, you know, not open myself to any criticism and write it as I was writing it. Or I could say, well, no, I've just got to call it the way I see it. I've got to be, you know, it's an academic textbook. I have to be a bit scientific. Let's open myself up to some, potentially up in some criticism, but that's unfortunate, you know, that's what the public expects us to do.
Mm-hmm. Yeah. And that's the thing too, is that, you know, when we're in, you know, in the medicine, I'm sure you come across this, you know, on different, you know, surgical rotations or, you know, or just come across it in the hospitals when someone has like diverticulitis or bowel anastomoses or conservatively treated appendicitis, what was the first thing they do? They put them on a low residue diet. They put them on a low to no fiber diet because this has to rest the bowel. Well, why is that? I mean, wouldn't that mean that there's inherent harm being caused by the fiber? If fiber was good for you, if this gave benefit to your colon, wouldn't that be exactly what you want in times of stress like that?
Yeah, but I know you and I have talked about this before. I actually did 2 colorectal surgery rotations as a junior doctor. Now, the choice was because I don't like doing night shifts, so I'd rather do colorectal surgery than stay awake all night. I'm just that kind of guy. But the patients there actually taught me a lot. And the interesting thing was looking at colostomy bags. And the patients are smarter than the doctors, because that figured out that if they just had low residue foods, you know, meats and things like that, that don't contain any fiber, then their bag, when it came to getting changed, it might have a little bit of fluid in it, but it had very, very little fecal matter, because everything they were eating was able to be digested and assimilated into their body. Whereas the fiber, and these, if they had a lot of vegetable matter, fruits and vegetables, then their bag would be overflowing. And this really speaks to the lie where you have these activists who say, oh, don't eat meat, it will putrefy in your stomach. And the exact opposite is true. So putrefaction, basically rotting under the action of bacteria, that's what fiber does. That's what foods that are non-maldigested do. If you're consuming something like meat and you've got a hyperacidic stomach that can help break it down and you absorb it all, then there's going to be very, very little residue that will come out of your gastrointestinal tract. And a lot of people, when they go to a meat-heavy diet, report to me, I've just got incredibly little amount of fecal matter, a very little fecal bulk. And, you know, so it actually was much nicer for the patients with the colostomy bag. So a colostomy bag is basically where you've had bowel surgery and you redirect the intestine coming out through the abdominal wall. And so people on a low residue diet, they had much more pleasant experience changing their colostomy bags.
Yeah. And that was something I saw as well. There was this study a while ago. They were looking at protein absorption from different sources, so plant sources and animal sources. And they found that, like, by studying people with colostomies, they feed them different things and they just study the contents of the colostomy bag. Very little of the animal-based protein was actually getting into the colostomy bag, or quite a large proportion of the plant proteins getting in there as well.